Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
I'm Wayne Stark, and let's talk about hypothermia. So, first things first, this is hypothermia, the systemic problem. There is a separate lecture about different cold injuries such as frostbite. So if that's what you're expecting, just wanted to be clear up front, that's a different lecture, cold injuries. So let's get started. So how is heat lost? So there's a couple ways that you lose it, and typically it's to the environment. So conductive with cold water immersion, you can lose it. There's some attendings in this group that like to do that sort of thing for charity. Also just being on a cold floor or some other cold surface. Convective, if you're in a cold environment, meaning the air is cold, particularly if it's windy, that's not particularly helpful. Now, you can't just radiate and lose heat to your environment. Most of us don't have an issue with that, but that is something to consider in the unbundled infant because they're just terrible at thermoregulation. So hypothermia, what happens? So your hypothalamus detects temperature change, and it does it one of two ways. There is communication with peripheral thermoreceptors, but it does have the capacity to just directly detect that change in core temperature. And so it's going to respond, and it's going to respond by trying to get you to conserve your heat and produce more. So you will shiver, and that's your muscle's way of moving to generate some heat, and vasoconstriction, because you don't want to lose any of that heat to your skin now. And also increasing your metabolism will occur. Often you'll sweat less or just abolish sweating altogether. That can be achieved so you don't lose any heat via evaporative losses. So contributing factors, there's a couple things that can set you up for hypothermia. Any disruption of the integumentary system, such as burns, can be a liability. There's some folks that unfortunately have CNS dysfunction, and they might have autonomic dysfunction that can set them up for hypothermia as well. Malnutrition, sepsis and infection, unfortunately can set you up where you're just not maintaining your normal integumentary system's ability to maintain heat, as well as CNS control of it. And certain metabolic and endocrine disorders will compromise your ability to maintain homeostasis, as well as toxins and ingestions. So what happens with hypothermia? Generally, the necessary process for life gets slower and then they stop. Let's talk about more specifically what that means. And so hypothermia is when that compensation we talked about with the hypothalamus fails. So you can get disordered respirations and then depressed, hypovolemia, and that can be vascular leak where you start to third space. Also, your kidney's ability to concentrate becomes impaired in hypothermia, and you get a cold diuresis where you'll just lose volume that way thanks to that impaired concentration. Decreased GI motility. You can even have pancreatic injury and necrosis. So that's something to keep in mind. You want a permissive hyperglycemia, because if the pancreas wakes up when you warm someone up, and resuscitating a hypothermic patient. Circulatory collapse is possible. You'll have increased myocardial irritability, and that's something to really consider during any resuscitative efforts, because the heart may not want to do what you want it to do until it's appropriately warmed up. And so when it's cold, it's more irritable, and the risk of arrhythmia is much higher. So you'll get decreased pulse rate, and that will ultimately lead to decreased cardiac output. But then there's also the risk of abnormal rhythms developing. Electrolyte derangements are not uncommon, and you can even have coagulopathy, and so DIC in extreme cases. And CNS deficits occur, and they tend to be just generally progressive. So it takes a while to get cold and die, but there are some features that can make it much worse. So you can drown more quickly when you're cold, unfortunately. And also, depending on what medium you're in when you're cold, if you're in cold water, you're going to get colder faster than if you're in cold air. So a lot of folks, if they get hypothermic, they can be resuscitated, and cold and dead can look very similar to cold and not dead. So possible Jack could have been resuscitated if she hadn't thrown him in the water. So in the pediatric world, you can have a good neurologic recovery if you're properly resuscitated, especially in pediatrics. But this is more common in non-asphyxial hypothermic arrest than in asphyxial. And what that basically means is that if you become cold and are not drowned prior to that, you're going to have a better chance of resuscitation. If unfortunately there's a drowning component, then it might be that there's some harm that occurred in a patient that's also concomitantly cold. So why are kids so different? Well, they have a large surface area to volume ratio, especially the neonates. They don't have much in the way of subcutaneous fat to insulate them particularly well. And so they're little radiators with not so great insulation, and they don't have great energy stores to make up the difference. And neonates are just really not great at thermogenesis. They're unable to shiver. They do metabolize brown fat, though, so they have something. Now, with hypothermia, I've taught this a few times over the years, and they've changed the classification. So I'm going to simplify it in a moment, but typically it's classified as less than 35 degrees. Now, mild, 32 to 35 degrees, is generally a different beast than moderate, severe, and profound. And so what I mean by that is, one of them, you're still shivering and compensating, and so supportive care is likely to be useful. Whereas when you start talking moderate, severe, and profound, supportive care where you just help a person to stay warm so that they can produce their own heat isn't going to work so well if they're fundamentally failing at trying to produce it. So while I will discuss all four of these, I'm going to try and bracket it so that we stay appropriate in our interventions. So external rewarming and supportive care will be appropriate in both mild and the other three, but you're really going to need to be more invasive and provide internal rewarming for moderate, severe, and profound. So let's talk about mild. So with mild, they're shivering, they're tachycardic, they're tachypnic. They may be confused. There could be amnesia and ataxia. You can remember from earlier how we mentioned there are CNS deficits and they tend to be progressive. But here, external rewarming and supportive care may be sufficient, and often is. Now, moderate, the patient's getting sicker. They're lethargic, they're stupor. You can see pupillary dilatation as well as loss of shivering reflex. It's important to mention that they're not shivering here. So this is where compensation starts to fail and they're not making heat like they should. Muscle rigidity. They can have shallow breaths, bradypnea. They may not look like they're breathing. And that's more and more common, more profoundly hypothermic the patient becomes. So they're going to be bradycardic, and they may even have some dysrhythmias. And so you can see how someone who's cold could look like someone who's dead. So that's something to be mindful of. So in these patients, when you start going moderate and progressing through greater degrees of severity, you're starting to consider invasive internal rewarming measures. Same with severe and profound. Here, unfortunately, they do tend to look deceased, and they may be. So fixed dilated pupils, decreased, or loss of reflexes. They can have coma and rigor. They really can appear dead. You might notice RALs from pulmonary edema and apnea, hypotension, oliguria. Basically, I mentioned diuresis in the earlier phases, and ventricular dysrhythmias, even asystole may be noted. And I've included the brackets, but I haven't read the numbers here, but I will backtrack briefly. So with mild, we're talking 32 to 35 degrees. With the rest, we're talking much colder, moderate 28 to 32. And with severe and profound, 25 to 28, profound being below 25 degrees. So once again, invasive internal rewarming is what we're considering in all of these patients. So for all hypothermia, there's some things we're going to do, and we're going to discuss some of the pre-hospital treatment of hypothermia. So we want to prevent further heat loss, and we want to facilitate rewarming. So we're going to get rid of any cold or wet clothing. We're going to put some warm, dry clothing on them. We're going to try to get their core temperature. This is not a good time for an axillary temperature, or so if they got to do a rectal probe, they got to do a rectal probe. Continuous respiratory and CV monitoring. We mentioned that they can have respiratory failure and hypopnea, also that at risk for arrhythmia. And check blood glucose. If there's something treatable there, we should be prepared and we should do it. So get them warm and dry and covered to optimize passive rewarming, but don't jostle them because as mentioned with the moderate, severe, and profound, they're at risk for arrhythmias and dysrhythmias. So we don't want to provoke that. So this is a hypothetical. What if you're hiking and you come upon someone and they're a victim of hypothermia? Well, it takes a lot to heat up another person, and you can't really reliably correct hypothermia in the field. So if you can't take them with you easily, leave them and go get help. Skin to skin won't help. The idea of you climbing into a sleeping bag with another person and warming them up is sort of like you trying to thaw your steak for dinner if it weighs as much as you. It's not going to happen. So you need to be practical about that and realize that the best thing you can do is go get them the help they need instead of providing something that is completely inadequate. Also, jostling them when you move them is not safe. So, pre-hospital treatment again. For mild, get them warm, dry, covered, give them warm, sugary drinks. And pretty much all of you guys have seen this. We've all done this. Enjoy hot cocoa. So pretty straightforward and basic stuff here. Supportive care, we're still counting on them being able to produce their own heat. We're just trying to help them. Unfortunately, with moderate, severe, and profound, that's a different scenario. They're in a lot more danger. And while we can do supportive care by covering them and trying to minimize heat loss, we have to be careful about how we manage them. So you don't want to jostle them, as mentioned. They're going to be prone to arrhythmia. Um, also, keep them horizontal because they're likely going to have autonomic dysfunction. So we can't count on lifting them upright and that working well for them. So support the A's, B's, and C's. If they're not breathing and you need to intubate, go ahead. Give them IV fluids. And they might require a lot because they can have quite a bit in the way of fluid shifts to make them hypovolemic. So hypothermia is largely a clinical diagnosis, so there's no single lab test to prove it. It's really just measuring their temperature. Now, labs and imaging, while they may not be necessary for mild, you should really consider them in moderate, severe, and profound because you can find things that you need to fix or correct. So chest x-ray looking for edema. Also, you can check CBC and coags, as well as electrolytes and, yes, glucose, so we can support them in any way that they might need there. I mentioned electrolytes. A CMP would cover all of these, so you can look at LFTs and renal function because you might see some end organ damage. Also consider trauma, depending on how the scenario in which the patient became hypothermic. Did they fall? How did they get stuck outside? Is there some metabolic dysfunction or toxicologic issue that left them outside, such as an intoxication or something to that effect, or were they found down because of poorly treated other medical problem? Also consider an EKG. We've mentioned several times the risk of arrhythmia, so you might want to consider that. So some certain special considerations, and I mentioned that EKG, but just in case I forget to mention it later, you might need to increase the your ability to detect it. Just maximize what you can on that EKG lead so that you can properly see it, because they might have very low electrical activity, but it might be present. So special considerations. Many clinical thermometers don't read well below 34 degrees, so you need a low reading thermometer. I've checked at 2 of the 3 main ER sites that we have here in Louisville that as pediatric ER doctors work, and the generic one that you use that we can give out that is disposable, as well as the ones with the disposable tips, aren't particularly reliable below 34 degrees. So we do have the low reading thermometers, and you might need to specifically ask for that if it's not brought out to you. Also, in terms of resuscitation fluids, lactated ringers requires a functioning liver. So if you're assuming that they're hypoperfused and that they're cold and the liver may not be working well, LR is not a good choice, so avoid that. In terms of rewarming methods, for mild, we talked about passive rewarming, but for moderate and severe and profound, I keep mentioning active rewarming and these invasive and non-invasive ways of doing it, but let's talk more specifically about what that really means. So for non-invasive, you're trying to minimize losses, warm the exterior, and you're counting on the patient to self-warm and shiver. So that's really only useful for the mild ones, but if you're talking about someone who's moderate, severe, and profound, you really need to put some heat into them. You need to get energy into that patient. So because of their absent and diminished thermogenesis, you're going to have to do something a little more stringent. So what does that look like? Well, some things that can be done actively, some of the non-invasive things that you can do, inhaled air and IV fluids in the field, 40 to, or rather not necessarily in the field, but 40 to 44 degrees. You can also put heat packs to the groins and axilla. This is not all that different from heat illness, where you can use cold packs in the same area. And what you're trying to do is target areas where there's large vessels and a decent amount of blood flow. Overhead warmers are appropriate. You can do warm water baths, although those may not always be practical. And electric blankets and thermal mattresses you can consider. Now, invasive, there's a couple different invasive techniques that we'll discuss. Peritoneal lavage, thoracic cavity lavage, as well as thoracotomy with mediastinal irrigation. I'm really not getting into the mediastinal irrigation here, just the thoracotomy. And ECMO is always an option when you have someone who's the wrong temperature and you need to fix it. So rewarming considerations. Heated IV fluids and inspired air don't really provide a lot of heat. They do help to prevent loss, but they don't really provide much. You're not really heating the patient up a ton there. Whereas irrigation considerations, you can do stomach, colon, and bladder, not a huge mucosal surface. And the other issue is if you're hypothermic, you often have splanchnic vasoconstriction, so they may not have a lot of volume of blood flow going to their stomach, colon, or bladder. So even if you do provide warmth there, it may not really be affecting the patient as much as we'd hope. So where do we put the warm fluids that we can hopefully have better success? So, well, peritoneal lavage is one, and this is done comparable to like if someone was doing a DPL. It's invasive. You basically will infuse about 10 to 20 milliliters per kilo every 20 minutes of warm fluids. And what you're trying to do is really just put warm fluids in them and warm them up internally. You could also do the same thing basically with a thorax. Now this requires 2 chest tubes, one to put the warm water in, or warm saline in, and one to let it out. But this way you're getting more to their core where their heart and lungs are, and you can try to heat them up that way. That's the same principle behind thoracotomy with mediastinal irrigation. And last but certainly not least is ECMO. That's a great way of trying to manage someone's temperature when they're either hyperthermic or hypothermic. And so to sort of make that point, here's a review of the different rewarming methods. And so passive rewarming is not that great in terms of speed. However, it requires the patient to be participating in that they're providing their own warmth. Now, IV fluids are fine, and that's one that's very, very commonly done. But when you try to look at what kind of effect they have, where your best rates are, a lot of these active internal lavage, like bladder, gastric, not so great. And we did mention how you can have that splanchnic vasoconstriction, which may impair this. Whereas peritoneal and thoracic lavage is even better. And then when you're talking dialysis or different ECMO methods, those are by far the best. So that's the best way to get warmth into a person and treat their hypothermia. So one thing to be aware of is there's something called an after drop. And so when you have a person who's hypothermic, externally their core, externally they're colder than their core typically. And so they'll have decreased core temperature, but relative to the periphery is far colder. And so when you start to try to rewarm this person, if you concentrate on external rewarming efforts, then you're going to warm their skin, you're going to warm them externally, and then if their body decides to perfuse that relatively colder periphery, then you're going to have cold acidemic blood from that periphery now perfused and shunting to the core, which was relatively warmer to the periphery. Now that colder peripheral and acidemic peripheral blood now shunting to the core is what is thought to cause after drop. So this is more common with peripheral warming techniques and less common with core warming techniques, but it is something to be aware of because it can look like your interventions aren't working. Also would like to discuss some CPR considerations because we had talked about how they can be prone to arrhythmias and you don't want to jostle moderate, severe, and profound patients, particularly the severe and profound. So it has actually been shown that some of these arrhythmias will resolve just with rewarming the patient. And with ventricular arrhythmias, atrial tend to go away with rewarming, and you can just ignore them. Ventricular arrhythmias, commonly they'll have transient ones. A lot of the medications and interventions that we do haven't really been proven to be useful in hypothermia. So be mindful that if you're running a code in hypothermia, considering what medicines to give, or if you should electrically cardiovert, while that's a reasonable consideration, practically the medicine's probably not going to work based on the patient's temperature. So worth noting an EKG change that is common. It's pathognomonic, but it is not exactly prognostic nor specific. And so general EKG changes that you'll see is prolongation of intervals. And so first it'll be PR, and then the QRS interval, and then the QT interval. But there's this Osborne wave that is very specific to hypothermia, and that's called, nicknamed the hypothermic hump, and you can see it right here at the QRS and ST junction. And so most commonly leads 2, as well as V3 through V6. Not really prognostic nor specific as mentioned. It is just more, but it is kind of pathognomonic for hypothermia. So, all right, so back to those CPR considerations. In severe hypothermia, the patient can look dead. It can mimic death. They might be technically alive, but if you can't appreciate that they're breathing, there's things you can do, such as checking the ET tube for vapor, or even a glass, holding a piece of glass next to them, or a mirror and looking for a vapor trail. Similarly, pulses can be very difficult to palpate, even impossible. So it's reasonable to take a good minute trying to feel for a pulse. Ultrasound is a modality you can use to try to see if you see any cardiac activity. And cardiac monitors, previously had mentioned difficulty with detecting cardiac electrical activity, so maximize that amplification if you're not seeing anything easily. And so there's things to consider, because if someone dies when it's cold out, they will be cold and dead. And if someone is a victim of hypothermia, they may look cold, but may not be dead. And that can be a difficult thing to distinguish. So if there's signs of life, we need to warm them. And if there's no signs of life, CPR. So fluid replacement's essential. We'd mentioned how hypovolemia and hypotension are common. Now, if you see VTAC and VFib, you can defibrillate them once. Now, this recommendation came from a wilderness medicine lecture. The recommendations here vary quite a bit, but common themes are that medicines during resuscitation and electrical therapy during resuscitation in the hypothermic patient are questionable. Really, you need to warm them up to try to reverse and improve their situation. So it is reasonable to defibrillate, but the wilderness medicine course that I took basically said, let's just do that, but once. If it doesn't work, it's probably more of an issue from an arrhythmia due to their hypothermia, and if you don't correct that, there's not much point in electrical medicine at that point. So defer further attempts until their core temperature is at least 30 degrees or greater. So spontaneous conversion to perfusing rhythm has been reported due to rewarming alone. So it's not that we're not trying to resuscitate them, it's just more of a acknowledgement that the reason that they're coding is because of their hypothermia primarily, and that the poor perfusion is secondary to that, and if we can correct that, we can help them to help themselves. So, once again though, how do you know if someone is hypothermic or they died and you've just found them cold? And so this can be tricky because cardiac arrest is tolerated. There are reports of people who were cold down to 20 degrees for up to 30 minutes without clinically significant neurologic or neuropsychologic deficits, meaning that they were cold and pretty dead looking and in arrest, and they were warmed up and now they're fine. So if you have that understanding that that's a possibility, then how do you tell these cases apart? And so when you have documented cases of full recovery from hypothermia-induced arrest, and now be mindful, we talked about how earlier that's not hypoxic before they become hypothermic. So unfortunately, the asphyxial arrests underwater, while there are case studies of them doing well as well, it's classically someone who becomes hypothermic, but they're not hypoxic or they didn't asphyxiate it ahead of time. So how to tell if they're cold and dead, or if they're just a cold person that's dying? Well, you can warm them up, and that's what you should do, and you have to get them warm to tell. So how warm do they have to be before they're dead? So if hypothermia is thought to be the cause of the arrest, not someone who's dead and cold, but someone who's hypothermic and is now sick and struggling from that, and that's the primary cause of their arrest. If you get them to you're supposed to get them to 32 to 34 degrees Celsius before declaring death. So the old adage is you're not dead until you're warm and dead. So if you think hypothermia is the cause of their arrest, then what you should do is warm them. And the reason I give you a range of 32 to 34 degrees is I didn't find a clear consensus depending on what source I checked. So they can look dead but have good prognosis, but rewarming isn't easy to do. We looked at some of the invasive rewarming methods, and I can imagine that none of them looked easy to you guys, seeing like ECMO and such. So is there any quick way to assess and say, okay, unfortunately, this person is cold and deceased? And so what has been published is using potassium as a marker for cell death. So potassium greater than 10 in a non-hemolyzed sample is generally assumed not to be survivable. Now, granted, this comes more from adult data and wilderness and survival data, but that's one way of saying, okay, I think this person's hypothermic and experiencing cell death and likely, unfortunately, has passed. So a non-hemolyzed victim that's in cardiac arrest to at least 34 degrees. In the PEDS text, the adult text tend to put the temperature of getting them to 32 degrees before calling it, before declaring death and withdrawing life support efforts. So warm them up. But if they have elevated potassium, that is concerning that they're actually having cell death and that they're deceased. So disposition. So this case is specific, but it's a case by case. But if you warm up a mild hypothermia victim, and there's no other concerns, I don't see why they couldn't be discharged home, and that is what the literature supports. However, with moderate, severe, and profound, it's really going to depend what interventions they need and what level, and that will help to determine the level of care. But it is reasonable to assume that patient is going to need to go to the pediatric intensive care unit. So there's my references. Have a great day.